Without further delay, I'd like to introduce the last student group. So it's Scott Bernards, Eric Demers, Jordan Miller, Jesse Shelton, Tristan Vandergrove and Emily Weston, and they'll be speaking about estimating pediatric weights by paramedic students. Give them a round.
Hello everybody, thank you for coming today. My name is Scott. I'm joined on stage by Jordan, Tristan, Jesse, Eric, and Emily. We'd like to talk to you today about our research question, can paramedic students accurately estimate pediatric weights? But first, a question for the audience, and please do feel free to voice an answer if one comes to you. How much would you say this adult polar bear weighs?
400 pounds.
I hear 400 pounds. 400, 1,000.
700. Enough to break ice.
Enough to break the ice. The answer that I was relieved to hear, to get this rolling a little bit smoother. Now, to give you the exact weight, I might have to consult with David Attenborough on that one. I'm not sure how much an adult polar bear does weigh, but I can tell you that it's enough to receive 0.5 milligrams of epinephrine injected IM for suspected anaphylaxis. I can tell that by eyeballing the adult polar bear. I'm not so sure about those two young cubs though. I might have to work at that a little bit harder to figure out what my dose would be. And therein lies the nature of our research. So I will be going over a quick introduction of our research. Eric will talk about the importance. We'll move to Emily to review our literature. Methodology will be discussed by Tristan. Jordan will talk about implications, and finally data by Jesse. So it's no secret that we have to rely on weight-based dosages in our practice as paramedics or as paramedic students. This is evident by looking at the basic life support or advanced life support patient care standards. There are many examples if you open up those documents you can find within our core directives. However, determining what those weights are to base your dosages could be a little tricky. It's agreed upon that perhaps the most accurate way to do this is to simply ask your patient. Ask him or her, how much do you weigh? The same can be said for pediatric patients. Sometimes the best thing is to ask the patient or to ask the patient's mother or father, how much does your child weigh? This is not always an option. Sometimes it's tricky based on levels of responsiveness, or perhaps there could be a language barrier that prevents you from doing this. In that case, we sometimes do have tools in the pre-hospital setting. You could use a Broslow tape or perhaps a popper tape. But these are tools that are not common to every service. Not every truck has these tools on board. Not every paramedic is familiar with these tools. So we move to some calculation-based estimations, and these are commonly done by estimating based on age. So maybe an age times 2 plus 10, or an age times 2 plus 8, even an age times 3 plus 7. These are all common examples of formula that our research team has found. But again, these do little to incorporate the relative size of patients and are more or less based on strictly just the age of the patient. So there must be a better way to do it, and we find ourselves as students, later in our careers as paramedics, having to sometimes rely on our visual estimation skills, and that is the importance that we would like to stress today. And I'll pass it over to Eric to further that point.
Thank you, Scott. So my name's Eric, and today I'll be asking you the question, why do we think it's important for paramedic students to accurately identify weights in pediatric patients? So one of the things that most of us here, if not there are some in the crowd already, is we're going to be paramedics on the road very soon, treating our patients with our symptom relief and other interventions that we can do. Many of these interventions come down to weight-based calculations for medications. One of those medications, such as dextrose, comes in a 10% solution and a 50% solution. And each one of these medications are given based on the patient's weight. So if you estimate a weight and you're off as much as 20 kilograms, then you could theoretically be overdosing your patient on something like dextrose and putting that patient in with the possibility of rebound hypoglycemia as well. Another thing we can look at is fluid overload in patients, especially when it comes down to pediatric patients. They don't have the ability to compensate as well as adults do. So the key point to get the right amount of medication or the right amount of fluid into this pediatric patient so that you're not causing any more harm. Another thing that I want to stress on is the research for pediatric patients and estimating weights. So far it's only been conducted in Australia, so we're mirroring our research based off of them. So we want to bring it here to Canada and hopefully to other countries around the world. Hopefully we'll get more research and there will be more results in terms of whether or not we can accurately identify weights in patients. Another thing too is just the education behind this as well. So we want to bring the attention that maybe there will be a need for change in education amongst paramedic programs across Canada or in other countries around the world. Finally, I want to talk about patient advocacy. As paramedics out on the road, our main goal is to be patient advocates. So one of those things comes down to do no harm. And basically what that means is to prevent harm to your patient by not overdosing, underdosing, and bringing the patient to the hospital with the best possible patient care provided by us as paramedics. So now I'll pass it over to Emily, who's going to talk to us about our literature review.
Thank you, Eric. So to start our project here, we went on to CINAHL Plus with full text and Medline databases, and we plugged in some words, including but not limited to pediatrics, children, weight, kilogram, pounds, pre-hospital, emergency, paramedics. So of those terms, once combined, we found a total of 150 results, and we narrowed it down to 5, simply for the fact that those were more focused on what we were looking for. So the first one that I'm going to talk about is Young and Kreutzer in 2016. So they simply decided to take 8 previous studies that looked at different ways to estimate weight. So they used an age-based formula, a length-based formula, and by simply asking the parents or guardians at the time. So they actually found that the most accurate method was to ask someone nearby related to the patient how much the person weighed. They found that the least accurate was the age-based. So the one that we are taught in class was actually the least accurate method. They stated that there are no methods currently available to us that are most accurate, and that there needs to be one created that is equipment-free, easy to use, and includes kids from all populations. So the next one that we used was done by Vilke all in 2001. So they took 20 medics working in San Diego County with an average of 6 years experience, and they were asked to go to 4 patients, real-life pediatric patients, calculate their weight based on estimation, simply by looking at the patient, and then administer the first dose of epi for a cardiac arrest as per their county protocol. So from that study, they found that less than half of the 20 medics were comfortable working pediatric calls, and only less than 75% felt comfortable estimating weights of those pediatrics. Of the 20 medics with the 4 patients, they found that 10% of the epinephrine doses that were calculated and administered were actually overdosed by a factor of 10. So 10 times the factor of the actual dose was given, which is obviously not very good. So third one there was done by Engelmeyer et al. In 2004. So they took to hospital ERs and found 396 medically stable patients. Now they used people over the age of 17, so they used adults. They used attending and resident physicians, paramedics and nurses, and as well as just asking the patient themselves how much they weighed. And of those 5 groups, the paramedics guessed the worst. So they found that the paramedics out of all 5 groups that are required to estimate weight actually estimated the worst of all of them. They found that 21.5% of the guesses of the paramedics were within 5% of the weight, which is not good as well. So the last 2 that I'm going to talk about were done by Williams et al. The first one in 2010. So these 2 were actually what we based our study off of, which Tristan will talk about in a little bit. But they took pictures of patients, varying ages, varying weights, and they did a slideshow, a PowerPoint slideshow. So they had 2 images of the patients up on a slideshow for 15 seconds, and their participants were asked to guess the weight of the patient and write it down. So like I said, that's kind of what we based ours off of. But they found from their study that of the 7 patients' pictures that were posted up on the slideshow, 16% of their participants were within 5% of the weight, and only 73.2% were within 20% of the weight. So for those of you that don't know, 20% weight difference can be quite a lot of weight added, which can affect a dose of medication quite significantly. So the last study was done by Williams with Boyle in 2015. So it was the same PowerPoint, but they found that of their nursing students and medic students, that the medical students actually did the worst again. So they concluded that most students underestimated the weights simply for the fact that they could not guess appropriately. So I'm going to turn it over to Tristan, who's going to talk more about our methods.
Okay, so I'll be talking to you guys about the methodology that we used for our study. So I'm just going to briefly go over our population, our study design, the materials we used to conduct the actual study, and the procedure that we followed for both first and second year paramedic students. So for our population, we included first year and second year PCP students here at Fanshawe College. The participants ranged in females and males with a total of 67 students participating in our study. The only people who were excluded from our study were people who had prior knowledge of one or more of the pediatrics that we used in our PowerPoint, as some of them were professors and instructors. Children, so if they were in the lab before and somebody had used them before, they were excluded from our study. For our study design, we conducted a prospective observational study where we looked to see if first and second year students could accurately estimate pediatric weights through images via PowerPoint. So the pediatrics were not actually in the room. We took some pictures that I'll explain a little bit more with the actual procedure. So the materials that we used for the study were a Nikon D7200 camera with a tripod. So it was the same camera, same tripod taken for all the 10 photos that we used. The tripod was set at the same height and the same distance away for every picture, as well as the background. We try to keep as consistent as possible with just a plain white wall. Just to add some ease for looking at a picture and trying to estimate weight, we added the BLS bag that we have here at Fanshawe College that we use in the lab, just because as a group we thought that everybody who would be participating in the study would have a good grasp of the size of it, so it was kind of a size reference we tried to put into the pictures so it wasn't as difficult to estimate. So this is one of the pictures that we had taken for the PowerPoint. We did not actually include this one in our study. PowerPoint, so this is just kind of something for you guys to look at. We also provided an answer sheet for them, the participants, to record their answers on. It had a spot for their estimated weight, whether it was in pounds or kilograms, a randomized identification number to keep it completely anonymous, as well as an area to select if they're PCP1 or PCP2 students, as well as male or female. So as for how we ran our presentation, we had all the participants in a classroom that acted as a closed environment, just so we'd have zero distractions for the participants to make their estimations of the PowerPoint. Before we started, we explained that they'd be shown an image of a pediatric with a frontal view and a lateral view, like you see up there, and that they would be given 15 seconds to think of their estimation and record it before moving on to the next. At this point, we also just wanted to kind of reiterate that this presentation wasn't meant to be a stressful experience for them. It was strictly just to see if they could identify weights of the pediatric patients, which is why we had it in a closed environment for all of our presentations. We also explained that the pediatric images would have a black bar across the eyes of the child in the image, just so that when the first picture came up, it didn't catch anybody off guard and distract them from their first answer, so we could keep all of the time periods consistent. After all the answer sheets were collected, after all the after all the answer sheets were collected by the collection team of myself and Jordan, we told the participants that if they wished to not actually participate in the study, they could leave before we started the presentation, but we just asked that once the presentation started, that they stay for the entire presentation. So with that, I'm going to pass it off to Jordan.
Good afternoon, everyone. I'd like to start by just asking everyone a couple questions. They're kind of inspired by the Price is Right game cliffhanger up behind me. The first is, who here feels that they could look at a pediatric patient and estimate their weight within 5 pounds the majority of the time? No one? Yeah, me neither. Okay. How about within 10 pounds? Okay, so we might be sending someone off the cliff. That's okay. So going into our study, we hypothesized that the first and second year paramedic students would both be unable to accurately estimate pediatric weights. In addition, we anticipated that the second years would not be able to perform at a higher level of competence compared to the first years. Previous research has shown that working paramedics have a tendency to overestimate pediatric weight, and so we thought we'd see a similar trend with the first and second years. And basically, if our results show that the students cannot estimate weights properly, we would just recommend that the students receive kind of further exposure to pediatric patients, whether it's in lab, out in placements. And we'd like to see new comprehensive tools be introduced so that medics and students can both use them in the future to help estimate. And I will now give it over to Jesse, who will go over our results.
Thank you, Jordan. So regarding our data, we use SPSS just to analyze our data for our 10 pediatric patients, which are referred to as subjects in our upcoming tables. Descriptive stats were determined to determine trends as well as comparison t-tests. Participants were given the options to estimate weight in either pounds or kilograms. All the tables today have been presented to you in kilograms. So of the 67 participants, we had a total of 38 first years and 29 second years. And of the 67 participants, 33 of them were females and 34 of them were males. So here in Table 1 behind me, we have all 10 subjects, their actual weights, mean estimation, minimum and maximum estimation, and range of our 67 participants. Of our subjects, B and F were the most accurate within 0.02 kilograms. A, C, E, H, I, and J were all underestimated with most notably A and C under by more than 8 kilograms, and I and J by under more than 5 kilograms. Subjects D and G were overestimated, with notably G over by more than 4 kilograms. Here in Table 2, we have the percent estimate within actual weights. Overall, only 18.8% estimated were within 5%, 38.4% fell within 10%, and 62.4% fell within 20% of the actual weights. To give you perspective, of the 67 participants for each of the categories 5, 10, and 20, 12, 26, and 42 participants represent each of these categories of the participants. The most accurate subject was E, when looking at 5 and 20% estimation range, and subjects F and H were the least accurate when looking at 5 and 20% range of estimation. Here in Table 3 is our first t-test comparison when comparing first and second year estimation. Statistical significance was observed only in subject J with a p-value of less than 0.05. Overall, second year students were found on average to underestimate weights in 7 of the 10 subjects, whereas first years underestimated in 5 of the 10 subjects. The average weight estimation by second year students was lower than the average estimation by first year students in 8 of the 10 patients. Finally, here in Table 4, we are comparing the estimation between female and male estimation. The only statistical significance we found was J, again. P-value was below 0.05. Overall, females were found on average to underestimate weights in 5 of the 10 subjects, whereas males underestimated in 7 of the 10 subjects. The average weight estimation by male students was lower than that of female students in 8 of the 10 subjects. So to briefly conclude our findings, first and second year paramedic students cannot accurately estimate pediatric weights, nor were second year students any more accurate than first year students. One trend that we did observe though that was different was that we tend to underestimate as opposed to overestimating pediatric weights. That concludes our study. I would like to open up the floor to any questions now.
Thank you, Kate, PCP student, and I apologize if I missed this in your presentation, but of the pediatrics that you had photos of, were they kind of a wide range of ages and weights therefore, or were they kind of all around the same age? Like, I'm kind of wondering, were they be worse or better at infant kind of age versus maybe, 10 or 12 year olds kind of thing?
So we actually did have a wide range. We had as young as 1 year old to as old as, I believe, 16. So we did span the age of all pediatrics. Your question about whether they were better with younger ages versus older ages, I can't personally talk about. We didn't actually give our data analysis team the ages of the patients. We simply just gave them the weights. So I'm not sure if that's something that we actually did consider, but we have the data that we could go back and figure that out, yes. Does that answer your question?
Yeah, thanks, Emily.
Alberto, PCP student. Just wondering, compared to the, from your lit review, all the data that you found for that, were your results similar, or were we less accurate, more accurate than what you found previously?
Thank you for the question, Alberto. Generally, we found that the results that we got from our study, and keeping in mind that we closely mirrored a study done by an Australian research team led by Williams, our results did very closely mirror theirs. In fact, the second table that Jesse showed with the percent ranges. I believe 18.8% of the estimations made by our first year and second year students were within the 5% range. I can't recall the exact number that Williams and that research team got themselves, but it was very close to that. And our trends showed very similar to theirs as well. Thank you. Thanks.
Sorry guys, one more. Kate again. Just from talking with you guys previous to this study, I believe you maybe let people answer in pounds or kilograms depending on what they were most comfortable with, just because of the speed of the study. Did you find that people were more accurate or less accurate depending on whether they were answering in pounds or kilograms?
Thanks for the question, Kate. I'll answer this strictly because I was part of the analysis team with the data, so I got to see kind of the data in initial stages and see what estimations were coming through in pounds or kilograms. So of the 67 samples that we collected in estimations, 5 of them, so 5 students, answered strictly in kilograms. 2 students chose to do a bit of a mixture. Some subjects, they answered in kilograms, some in pounds. And again, there's no penalty for that. We told our participants that they were free to choose whichever they would like. And as researchers, we would convert to a common system, and we used kilograms for that. So 5 students using kilograms, 2 students using a mixture, and the rest of our 67, so 60 students chose to use pounds exclusively. We did not take a look at whether or not estimating in kilograms versus pounds was any more or less accurate, but given that there was such a small sample of people that chose to use exclusively kilograms, it would be difficult to prove statistically that they would be any more or less accurate, considering there was only 5 people that did that. Thanks.
Hi guys, Trevor, PCP student. Just a quick question around the timing for the people. So they were given a period of like a shortened time exposure to the actual image to make their estimation. Do you feel that would have impacted, depending on, you know, they're looking at it, they're trying to write it down, trying to do the math in their head. Where did you come up with that number for time, and do you feel that that might have impacted people's ability to estimate in comparison to maybe real life where, you know, they're doing their patient assessment and things like that, so they have a little bit more time exposed to the patient before they actually have to nail down an actual weight?
Thanks for the question there, Trevor. So basically what we chose was around 15 seconds for the time period allotted for that. And we as a research team, we haven't really found anywhere that gave us a time limit per se, but we just felt that 15 seconds would be more than enough for the estimation, because as paramedics, when we walk into a room, we have our first look and the first glance at the patient, and given that first look, you should be able to determine an estimation of how much they weigh in that time.
Okay, I just follow up to that. So with that, you didn't refer to any research prior on timing and the previous you built off of. Did they give the same time limit, or?
So the previous research that we built off, they didn't give a time saying exactly how much time was allotted in between each slide.
Oh, great, thank you.
I'd like to welcome Fanshawe alumni, Christina D'Alessandro, and I work with Christina in a couple of other venues, but Christina is currently pursuing a master's degree in health research methodology, and she's a PCP with York Region. She holds a Bachelor of Arts in Women's Studies from the University of Toronto and studied cardiovascular physiology at Dalhousie University. Her research interests include optimizing cardiovascular care in pre-hospital arena, with particular attention to the female population and the role of cardiac point-of-care ultrasound. Her work has spanned both realms of academia and advocacy for women's heart health, and she's going to speak to you today about women's heart health. So please give her a round of applause.
Thank you so much, Alan. It's an absolute honor and privilege to be your closing speaker today. So thank you so much for having me, and also thanks to my dad for being here today. So this is an enormous topic, and I am by no means an expert, and the more I understand, the more I realize that we don't understand. So this presentation is called Misunderstood, and it's intentionally borrowed by the Heart and Stroke 2018 Heart Report. So intentionally to bring awareness to that document. Parts of this presentation were from an older presentation called She Can Go to the Waiting Room, but is revamped and revisited for you today as a fully loaded and hopefully condensed consciousness-raising package. So what if? Take a second and dream with me. What if you were called Code 3 for a generally unwell patient? You arrive on scene to meet, let's say, Mrs. Schaefer. She's a 55-year-old woman. She's a 20-year history of smoking. Her chief complaint is unusual fatigue. She did have a little bit of mid-sternal chest pain prior to arrival, but it's resolved now. No other history to disclose, but she did mention that she doesn't like going to her doctor, and she hasn't seen an EP in many years. So as a good paramedic, as a good Fanshawe paramedic, because you're not only a good clinician, you're also an architect of progress, you always maintain a very high index of suspicion. So you do a 12 lead, and this is what you see. Maybe some subtle SD changes in the anterior and lateral leads, but nothing really too jumping out at you, let's say. So you give the talk that you will give 1 million times in your career. Mrs. Schaefer, all your vital signs are normal. Your ECG is not showing anything acute. It does not look like you're having a heart attack, but we should probably take you to the hospital anyway to get some blood work done. On the way to the hospital, you learn about her family, her deceased cats, her recent recovery from her tooth abscess. But what if you could look under the hood of this situation? What if you could have a mechanical lens, not just an electrical lens, to actually see her heart? She did have chest pain prior to arrival, but since it resolved, you didn't get what they say. So what if you had a handheld cardiac ultrasound device? Some people call it portable transthoracic echo, which it essentially is, but we like to call it HHCU to not mistake ourselves for cardiologists. And so what if you have your handheld echo? It's only 390 grams. It's made by GE Healthcare's V-Scan, and you have it in your toolkit, and you pull it out, and this is what you see. I think you could press. This is what you see. So what are we looking at? Is this an eyeball? Is this a stomach? Is this a trachea? No, this is the heart, because I'm always talking about hearts. So this is your parasternal short axis view, obtained when you place the probe on the left sternal border at the level of V3 and V4. The index marker is going to be pointing towards the left shoulder, and if you could play it once more. What you're seeing here is anterior wall hypokinesis. So let's bench all of that for now and look at some objectives. So we're getting a glimpse into the discrepancies in research, screening, and diagnosis of heart disease. We're going to gain some general but potent awareness into the sex-based pathophysiology of atherosclerosis, predominantly the differences between coronary artery disease and microcoronary dysfunction. And we'll have a brief overview of 3 acute coronary syndromes that are luckily now recognized as acute coronary syndromes because they weren't previously. Sorry, could you go back? Back one to the objective. And then the last objective is we're going to have a quick peek at POCUS. So, a little terminology disclaimer. The term woman here, used throughout this presentation, does not claim that all women have equal access to the healthcare system, nor does it claim that they're treated equally by healthcare providers. I'm also absolutely not proclaiming that cardiovascular risk factors don't vary greatly between ethnicity, because they absolutely do, especially in the South Asian, Chinese, and Afro-Caribbean populations. And they also vary greatly between socioeconomic status and geographic location. So today we're going to be moving beyond what's called the bikini approach. Where are my 2 first-year students that had a little bit of a debrief on this in February when I spoke to them at Heart Health Month? So you guys have a bit of an advantage here. and you're very well prepped for this conversation. So we're moving beyond the bikini approach, which is seeing women's health as the totality of breasts and reproductive organs. So what gets left out of this equation is, in fact, women's hearts and the role that reproductive hormones play in vascular health and homeostasis. We'll be moving today from a critical stenotic framework to cardiovascular care to a more multifactorial approach, which is very complex. So we're going to be shifting paradigms. So everyone is going to be moving from the left side to the right side. We're not going to leave anyone on the left side of the fence today. So these are a couple easy kind of to read pictorials from the Misunderstood report that I'll encourage you to follow up with after this presentation. It was compiled from a 14-minute online survey of 2,000 females conducted by Intentions Consulting between June 23rd and 29th in 2017. There's a total of 2,000 respondents, and these are some of the big sort of key stats that came up, which are things that we sort of always knew but didn't really have the American Heart Association's recognition of. So 2/3 of heart disease clinical research focuses on men, right? So we're behind not only in heart disease for research for women, but all areas of women's health, excuse me. So prior to 1993, women were absolutely excluded from all clinical trials in the United States, and prior to 1998, it was the exact same in Canada. Early heart attack signs are also missed, sorry, quick one. Early heart attack signs are also missed in 78% of women. I'm going to read that again. Early heart attack signs are missed in 78% of women. So those women could be your sister, your best friend, your 5th grade teacher, or your mother, as it was in my case. So it's a little playback actually to me and my mom at Fanshawe graduation. She's luckily still alive and well today. My mother actually had a very classical male pattern heart attack, which we all know very well, so I won't go over it. And luckily she survived without any intervention or hospitalization. The only footprint was a pathological Q wave on her ECG that appeared a couple years later. But every day I do live in fear that her cardiovascular care is mismanaged, and hopefully after the end of this presentation you'll understand why. So fact or myth, quick little game, no stress here, I'm going to give you all the answers. So fact or myth, number 1, most women die of cancer. What do you think? We hear a lot about breast cancer, so there must be more women dying of breast cancer. Right. So myth, 5 times as many women die of heart disease than breast cancer. The reason why that's not well understood is because heart disease doesn't have a strong enough PR campaign. So heart disease kills more women than all cancers combined. Number 2, heart disease is a man's problem. Fact or myth? So it's, again, a myth. More women have been dying of heart disease than men since the early 1980s. 1 woman every 20 minutes in Canada will die of heart disease. So in an 8-hour day, like today, there's approximately 24 women that will die. It's a leading cause of premature death in Canada. And in the United States, because they have better, more robust databases than we have, we're just starting to begin to formulate ours, but it's been estimated that 60,000 more women die of heart disease than men each year. Number 3 is another myth, again, so women and men with heart disease get the same care. 2016 New England Journal of Medicine study found that female heart patients under the age of 55 were 7 times more likely to be misdiagnosed by ER physicians than that of men of the same age. So they're misdiagnosed for having acid reflux, anxiety, depression, symptoms of menopause, fibromyalgia, or even just the common flu, essentially. But even when they are correctly recognized because their clinical presentations are similar to men's, they're still undertreated and underdiagnosed. So they're less likely than men to be placed on beta blockers, statins, ACE inhibitors, all that we know are very crucial for the prevention of future cardiac complications, or to receive implanted defibrillators or even aspirin for chest pain, like Mrs. Schaefer at the beginning of our presentation. The last point here is actually a fact. 60% of women who die of sudden cardiac death have no prior history of heart disease. So this is shocking, saddening, maddening fact. And the rate of sudden cardiac death of women in their 30s and 40s is actually increasing much faster than it is in men in the same cohort, rising 30% in the last decade. And part of this reason is potentially due to spontaneous coronary artery dissection, which we'll learn about, which has been reported in women as young as 17. So don't think that heart disease is an old woman's disease or a man disease for that reason. Okay, so we're going to be looking at the Women's Ischemia Syndrome evaluation. So this is Dr. Noelle Berry-Mertz. She's my absolute favorite cardiologist. Her work has shaped the trajectory of my whole life's career. And it took me 4 years to get the courage to just write her secretary an email. And yesterday I had the opportunity to meet her at the Ottawa Women's Heart Summit and actually have lunch with her and have a one-on-one peer mentoring session with her. So it was phenomenal, and conferences are expensive, but don't stop investing in them because they have big benefits. So on to WISE. So the Women's Ischemia Syndrome Evaluation, raise your hand if you've heard of it. That's common. Okay, so it began in 1996, 22 years ago. It's a division of the National Institute of Health. It's a branch of the Heart and Lung Foundation. The WISE, as I mentioned, is a landmark investigation. Dr. Noelle Berry-Mertz is out of the Cedars-Sinai Medical Center in Los Angeles, though there are 6 or 7 other sites and universities that collaborate with her, and she's really laying the groundwork for better ways to evaluate and treat women with heart disease. So it was the first major heart study to include women. Over the course of about the first 10 years, there's 25,000 participants, and it was designed principally to answer 3 questions. How does ischemic heart disease develop in women without arterial blockages? And there are multiple causes. Would some other cardiac imaging method provide better clues to ischemic heart disease in women? And what role does estrogen and other female hormones play? So today we'll be looking at these 3 studies here, and there'll be just very general key highlights from them. They're all published in the American Journal of Cardiology. The first one is published in 1999, and the bottom 2 are companion documents published in 2006. Let's talk about estrogen. So estrogen comprises a very diverse family. It plays a large role in vascular health and endothelial regulation. One of the largest reasons why women have a buildup of plaque in the microvasculature and their symptoms are so diffuse instead of the macrovasculature is due to estrogen. So what are the estrogens I have listed here? So we have estradiol at the top. Estradiol is predominant in the pre-menopausal years, and it's later converted through peripheral conversions of androgen in the adipose tissue in the postmenopausal years to estrone. And estriol, I'm probably pronouncing that wrong, is a metabolic byproduct of estradiol. So what's really important to remember from these slides is not the names of the different types of estrogens, but that there are different types of estrogens, that there's a predominance from one to the others and it shifts through a woman's lifespan, but also that women's blood vessels are exposed to extremely high changing levels of estrogen throughout our lives. First during regular menstruation, then pregnancy, potentially preeclampsia that has a whole other load of problems, gestational diabetes, and then before and after menopause. So these estrogen affects how blood vessels narrow and widen and how they respond to injury. And also, how they respond to injury and how they dictate change in the behavior of our vessels. The estrogen level in menopause is 1/10 what it was in premenopausal decades, so it changes very drastically. Awesome. Okay, so more on the WISE study. This is probably one of my favorite slides because it most simply describes the differences between male and female atherosclerotic phenotypes. So at the top we have the male pattern fatty plaque that has been nicknamed by Dr. Mertz as the beer belly plaque because it protrudes and it's uneven. So you have to remember that just as men and women put on weight differently in their bodies, the same thing happens with plaque in the heart. It looks different. So we have the beer belly, the top, which is the more male pattern, and then we have the female pattern at the bottom that is, as Dr. Noelle Berry-Mertz says, packed down nice and tidy. It's more even, and it's described to be more like cellulite. So what happens in the male pattern, sort of a beer belly plaque, is that it protrudes into the lumen of the artery. We know these we know this type of pathogenesis well, right? So it protrudes into the lumen, and then you have an explosion. You have an explosion, men explode, and this is a coronary thrombus because of a break in a fibrous cap, and it shows a protrusion into the vessel lumen. Whereas women erode. This is the coronary thrombus because of endothelial erosion, which causes constriction of the blood flow due to the narrowing of the artery. So this graph is a little bit older, and it's done on purpose because I want you to understand that women's heart disease, although now thankfully it's gaining a lot more traction in mainstream consciousness, it's not a small and a new problem, it's a big and an old problem. So this graph demonstrates the percentage change in coronary heart disease mortality in black and white women as compared with white men. It's always very important to take not only sex into account, but also race as well, and it's a very under-researched area, so that's why I also included this graph, is because I like the difference of the multiracial analysis. So as you can see here, this is between 1979 and 1998. We have a decline in mortality rates, is the bottom black line, for men. So it turns out that a system that's actually made to reduce heart disease in men, for men, by men, works really well in men, but not so much in women. Sorry, this goes ahead too quickly. So in women, you have the line here, the white females, their mortality rates aren't declining as much as this line, and then you see even less of a decline with African American women. So I apologize, it's a little bit blurry. I took it yesterday at Dr. Merce's closing speech. So apologies that it's a little bit blurry, but I really wanted it because there's very few graphs that we have, and absolutely none that we have yet in Canada, that depict mortality rates of cardiovascular disease in men and women. They usually just lump them together, or when they do, they don't make enough sort of more detailed analyses. So this is the cardiovascular disease mortality rate from 2000 to 2013, and this is in the United States from the WISE study. So you'll see a decline. However, this is not in any way, so there's actually a 43% reduction here from 1997 to 2007, which is phenomenal, but we're not actually seeing the same reduction in Canada. So let's talk about a few of the acute coronary syndromes. So cardiac syndrome X is the most historical one. It's exertional chest pain, exertional angina, positive stress test, and a negative angiogram. So this chest pain occurs in the absence of macrocoronary blockages. It can be present as STEMI, it can present as non-STEMI. There's a lot of differences in expert opinion. And then we have microcoronary dysfunction, which is also a form of cardiac syndrome X. So this is heart disease that affects, again, the tiny microvasculature in the subendocardial level, right? So there's a lot of epicardial, very epicardial heavy in our training, but let's talk about the microcoronary dysfunction and the microcoronary beds and the subendocardial level. So MCD occurs when there's damage to the inner walls of the arteries, like that very diffuse cellulitis kind of builds up of plaque, which causes a very poor constriction and dilation of endothelial dysfunction. So the symptoms can be very diffuse, and it can occur in both the presence and the absence of chest pain. So here we have the macrocoronary arteries, and the small ones zoomed in this picture to the top right there are the microcoronary arteries, because they exist. And this also explains well, as I mentioned before, why not as many women have the typical classic mid-sternal crushing chest pain with radiation to the left jaw, your diaphoresis, your palate. Sorry, this is an on and automatic thing, keeps jumping, sorry about that. So let's talk about the endothelium now. So what is the endothelium? Does anybody know? So the endothelium is a monolayer of cells covering the vascular lumen. For years it was thought to be a mere physical barrier between circulating blood and underlying tissue. But we now know that endothelial cells are metabolically active with very important paracrine, endocrine, and autocrine functions that are all absolutely indispensable for maintenance of vascular homeostasis. This is the chest pain that comes and goes. This is the chest pain that's non-specific. This is the chest pain that's hard to quantify. This is the chest pain that resolves prior to your arrival or comes back or only comes back a little bit. This is endothelium. This is endothelial dysfunction. This is microcoronary dysfunction. So what is spontaneous coronary artery dissection? It's probably the most terrifying. It's nicknamed the Phantom Menace. 80% of SCAD patients are women. As I mentioned, the average age is 42, but the Mayo Clinic reports cases as early as 17. If you Google SCAD, the first thing that will come up will be the Savannah College of Art and Design, so that's not the right SCAD. You have to put in spontaneous coronary artery dissection. So it's found typically in young females without classic coronary risk factors, and it's thought to be a very rare cause of acute coronary syndromes. So the prevalence of SCAD in ACS subjects is still unclear. The presentation is variable between STEMI, non-STEMI, unstable angina, or sudden ventricular arrhythmia. But this basically occurs when the inner and outer layers separate. The blood is going to pool, which forms a hematoma, which then causes an obstruction, okay? So it constitutes 25% of all heart attacks in women. And all heart attacks in women under 60. The cause, as I mentioned, is largely iatrogenic, so it's unknown, but has been linked to multiparity due to the heightened hormonal milieu and some connective tissue disorders such as Marfan's and Ehlers-Danlos. So SCAD is a very challenging diagnosis, even when these patients do present with STEMI-positive ECGs and they do get up to the cath lab. There's 3 types of artery dissection. Is only type 3 it's the least able to be diagnosed with radiotransluminescence in angiography. But as it says here by Dr. Esther Soo-Young Kim, SCAD is a challenging diagnosis for a number of reasons. While its appearance is very obvious on some coronary angiograms, on others it can mimic plaque or mild coronary artery disease caused by atherosclerosis. So this is our critical stenotic framework. This is the framework that we all currently live and work in. This is the framework that drives me crazy. This is the framework that gives me chest pain. So it's great. It works sometimes. It does not work for women, and let me tell you why. So we have, you're all Fanshawe grads, so you're all very aware of the atypical symptoms of cardiac ischemia and infarction in women. Give me a couple of them. Sorry?
Back pain?
Yep.
Fatigue?
Yep.
Nausea?
Yep. Excellent. Okay, so these are our more sort of Hollywood ones that now, luckily, due to the heart and stroke campaign, we're moving away from. So we have our chest pain, pallor, shortness of breath, diaphoresis. We do our ECG, explodes, STEMI. So we either do a cath lab activation, but definitely troponin testing, and then some stress testing as well. So the difficulty with this is that all the 3 ACS syndromes that I mentioned are very poorly detected in ECG. The sensitivity rate is extremely small. I didn't present any specific graphs for you today because there's still not a lot of expert consensus on exact levels, but it is absolutely deemed the most ineffective tool to see microcoronary dysfunction, to see cardiac syndrome X, and to see SCAD. Troponin levels as well, we'll get into that in a second. Might as well just go to the next slide now. So this is our more multifactorial approach, okay? This is my dream slide. This is the future model. So at the bottom we have all of our, so we're still considering our critical stenotic approach. It's absolutely important. It saves lives. We're keeping it. But we're also considering what this multifactorial approach is about. So at the bottom tier here, we have all the atypical symptoms, some of which you just described. And also no pain is a big one as well. And unusual fatigue, unfortunately, has an insane predominance as well. So please don't take that one off your radar. So then when we move up the tree here, what do we have? What are all these words? So for purposes of time, we can't go into it too much, but the first box here is the blood serum profile testing. So troponins having just a universal level for troponin elevation is not working for women. There's other biomarkers that hold way more promise for sensitivity for ischemia and infarction. Some of those are hypersensitive C-reactive proteins, interleukin-6, serum amyloid A's, and even, so the differences, like I said, and the specific levels for sex-specific markers are still being established, but there's a lot of promise with 60 nanograms per liter, and CBIN-1 that just came out of the conference yesterday. Handheld cardiac ultrasound, which I showed you at the beginning of this presentation, is another tool that I'm proposing as an emerging adjacent clinical competency to 12 and 15 lead ECGs, because we can detect mechanical changes that aren't yet seen on the ECG. Then we have IVUS and OCT, both very invasive, expensive, high-risk procedures, one using light, IVUS, or ultrasound, one using sound, and optical coherence tomography, which uses infrared light. Then we have SPECT and PET, single photon emission commuted tomography that uses gamma rays, and we have PET that uses positrons, but the golden standard that's proposed by Dr. Noel Berry-Mertz, which is the most sensitive for detection of MCD and chronic syndrome X, is cardiac MRI. The difficulty with that and the problem with that in our system is, unfortunately, obviously we're exposing people to ionizing radiation, which is never good, which ultrasound does not do, but CMRI is a very expensive test and is reserved for suspected pericarditis, congenital defects, and other abnormalities. So it's not traditionally used in these other settings. So just a quick recap so far. Symptoms, so we have our common CAD ones, coronary artery disease, versus our cardiac syndrome X, myocardial dysfunction, and SCAD ones. The pathology we've learned now, it's plaque lesions extending into the lumen versus constricted vessels, a more diffuse cellulitis type plaque phenotype. Diagnostic procedures I just briefly mentioned. And treatment, you will be surprised maybe to know that is actually mainstay anti-anginals and beta blockers and ACE inhibitors actually work very well for these women. The difficulty is that they're never actually placed on them because it's not recognized as being cardiac in origin. So moving from the stenotic approach to the multifactorial approach, shifting from left to right, we have also a shift in risk factors that I really want you to keep at the forefront of your mind in the field. And the only way you can do that is to have this awareness. So we all know the typical sort of criminals: obesity, inactivity, smoking, hypertension, hypercholesteremia, family history for age of 55, prior infarct. Keep all of those, obviously, risk factors that are crucial to the stenotic framework, but please add at least one or two of the multifactorial risk factors as well, even if it doesn't go anywhere, and even if you're just going to report it to the nurse. So one of those, or some of those, are menopause, autoimmune disorders, such as rheumatoid arthritis, lupus, cancer. These are emerging areas of investigation: cardiohematology, cardio-oncology. Depression increases your likelihood of MI. Polycystic ovarian syndrome, diabetes mellitus, metabolic syndrome, gestational diabetes. Did you have gestational diabetes? Did you have preeclampsia? How many children have you had? Please keep some of these in mind. So to draw focus, estrogen has a vital role in the maintenance of arterial wall elasticity. Its decrease in conversion to estrone have deleterious effects on endothelial function. Cardiac syndrome X, microcoronary dysfunction, and SCAD are not well detected by traditional screening tools in the critical stenotic framework. There are significant knowledge deficits that exist in cardiovascular care amongst all healthcare providers and patients alike. Our complacency in the stenotic framework is killing women. Women are under-researched, under-diagnosed, under-treated, underrepresented, causing them to be very misunderstood. So this is my brain break slide. We're almost done. So we're going to talk about a very tragic death in EMS. We're going to switch gears a little bit. We're going to talk about the death of the stethoscope. It was killed in cold blood by point-of-care ultrasound. What is POCUS? POCUS is what I think about all day, every day. I think about POCUS when I'm brushing my teeth. I think about POCUS when I'm parallel parking my car. I think about POCUS when I'm walking the dog. All day long, it's POCUS, POCUS, POCUS. So it's the most beautiful word I've ever heard, but it stands for point-of-care ultrasound. There are many, many uses of ultrasound. But in particular, it has the potential to detect segments of the left ventricle that are moving too slowly, too quickly, or not at all. So we have the potential to see ischemia and infarction mechanically before it shows electrically and before we have long time delays to wait for blood work. So point of care ultrasounds, the democratization of anatomical image. Please follow EMS POCUS. Differing from radiologic ultrasound, POCUS aims to answer a predetermined question with a yes or no answer. For example, is the cause of my patient's acute dyspnea the result of a pericardial effusion? Yes, no. How about I do a scan? Find out. It's an adjunct to the physical exam, does not replace our standards of care at all. It is the cherry on top of the cake of what we already do. So it does not replace or deny any patients any right to have ALS and BLS patient care standards. The echocardiography literature so far suggests that some experts report an 80 to 90% sensitivity for subendocardial ischemia and infarction, like cardiac syndrome X, like coronary or microcoronary dysfunction, but not for SCAD. But the WISE and the Mayo Clinic registry tend to disagree. They say it's probably, we can only see 1/3 of that, but I'm absolutely happy catching that 30% on the pre-hospital side of the fence. So there's many different types of POCUS devices, many types of ultrasound devices that are becoming more and more portable. On the top left here, you have the different types of probe. We have a linear phased and curved, linear phased and curved array. Mine is obviously my favorite is obviously the phased array, as that's the cardiac probe. In the middle here, we have the, in the middle here, we have the butterfly that's not available in Canada yet. But that is actually one probe for the entire body. And then next to the butterfly, we have the GE Healthcare's V-Scan. It weighs only 390 grams, smaller than a sandwich I'd eat for lunch, extremely portable. But POCUS is being used in other resource-limited environments as well. The bottom right, you'll see a Rwandan medical student doing a fast exam in Kigali, Rwanda. So, we know the blood supply, more or less, the big epicardial arteries, right, that supply all the tissues of the myocardium. So this is myocardial ischemia and infarction via an electrical lens. This is myocardial ischemia and infarction via a mechanical lens. So the American Society of Echo is very excited about propagating ultrasound with non-traditional users. They're very hesitant about it because times and optimal modes and methods of training have not been established, but they're definitely advocating for it. And in spirit of that advocacy, they've shortened the 17 segment understanding of myocardial perfusion into a 3-segment understanding of myocardial perfusion into anterior, lateral, and inferior segments. So as I said before, these are just, this is my work, these are theoretical projections for cardiac POCUS, where there be no time delay. So I'm proposing it as an emergent adjacent clinical competency, and with enough time and research, because it's already being approved by case reports all across the states, and especially in Kingston, out of the Cardiovascular Imaging Network, that it's actually being used as a bypass to cath. So before waiting for that second serial trope, they're getting emerge physicians, they're getting internal resident students to come in, do cardiac POCUS, see a regional wall motion abnormality, and then chat with the interventional cardiologist about it and get those patients to cath lab earlier. So these are some of my POCUS projects. I don't have a life anymore, and I'm totally happy with that. The most exciting one was the hybrid POCUS Echo Lab, provision for remote emergency streaming cardiac ultrasound POCUS. So that was actually proposed for the Innovation Challenge at the last conference of the ASC. So I'm not sure if we made it to semifinals yet because we don't have the results. But other POCUS projects are literature review. I'm actually looking for reviewers if anyone wants to sit down and read 5,000 journal articles with me. And we're also hoping to bring it as a feasibility study in land ambulances and maybe for paramedic students. So this is a just very quick video for Generation Eye Ultrasound that illustrates the live telestreaming technology. I don't know why this is going first, sorry. There we go. Go back. Yeah, there we go.
The world moves in real time. so should our healthcare technology. With information needed, decisions to make, and experience to share, every second counts. Live integrated teleultrasound enables real-time communication, remote collaboration, confidence, knowledge, and learning. The first ever integrated teleultrasound collaborative platform. Philips Lumify. Integrated teleultrasound powered by React's collaborative platform. Innovation and you, Philips.
And that concludes my presentation. Questions. Sure. One over here in front.
Hi, Isabel, PCP student. So I found a lot of that super interesting, the microcoronary dysfunction. I've never heard of that before, and I've had so many patients that kind of fit that description. It's really fascinating to be more informed about that. But my question is more about the doctors misdiagnosing. So I know in medicine in general, it's really well documented that male doctors tend to discredit female symptoms and what they're experiencing. And that is there any research regarding whether female doctors diagnose female patients more accurately?
Not that I know of. Maybe that's an area of research interest, if it interests you, that you could do, because it's definitely needed. But none that I know of. It's basically just been physicians grouped in general as their misdiagnosis. But I do also have an appreciation for how difficult the diagnosis can be when all of the tools that we're using to actually screen are ineffective. So as frustrating as it is to work in this system, I also appreciate that it is very difficult and highly nuanced. Are there any other questions?
Hi, Mike, PCP student. Just a couple questions. I'm just curious, because that video is really, really cool, and it's awesome to see how, I never realized how portable that can be. So it's definitely something logistically that we could definitely carry around with us. How much does one of those units cost?
Yeah, so that's a good question. I don't know. Yeah, and I'm not sort of the tech lead in the team, so I don't deal with any of that kind of stuff. But I know that the, for the iPad and the telestream, I have no idea how much that costs, but I do know that the V-Scan by GE Healthcare, that's widely being propagated by cardiologists and internal medicine residents, I'm having a stroke, is about $8,000. That's a small one, but not the one you're talking about. I don't know how much that one is.
And then, do you have any knowledge on how, I'm not sure how familiar you are with any literature or knowledge or whatever on how long it would take to potentially train people with zero experience?
That, my friend, is the $1 million question. So that's what we're working on right now. So we're writing proposals, working closely with cardiologists, especially at Queen's from the sync department. And at the end of this month, we'll have a better idea of even a timeline to sit down and get some really rough, malleable documents together. Because as exciting as it is and as easy as POCUS can look, and it's not easy, especially not cardiac POCUS. Lung ultrasound is easier. It's much easier to detect A lines and B lines. and see signs of congestive heart failure and see fluid overload than it is to do highly technical wall motion abnormality assessments. So the stuff that I'm hoping to do is unfortunately the most technically demanding side of the fence. So what it will start with, which is some of the proposals I'm writing now, are very basic image acquisition stuff. So it'll be a little bit similar to the implementation of 12 leads. Initially it was all about acquisition, and then it was about interpretation. So the phases I'm writing right now are triphasic models. The first one is, can a paramedic get a clean image on one plane? Then and how long did it take? And what is the quality of those images? And what percentage of those images can be considered high-yield diagnostic images? Then phase 2 will be, can a paramedic obtain a diagnostic quality image on all 4 planes? And phase 3 will be like, can a paramedic adequately assess left ventricular function? Can they rate it into categories of abnormal, normal, moderately decreased? So it's going to build very, very, very slowly. But the initial literature that's being suggested right now by Dr. Marjorie, who is my mentor out of Queens, with his resident students, is that 1 month of time. They did a trial with 1 month, had 2 arms, a technology arm and a conventional traditional arm, and they found a very high rate of false positive diagnoses, because we think the technology is small. Oh, this is on my iPhone, this is going to be easy, but that's actually pretty terrifying to cardiologists.
Great, thank you.
I think it was a great presentation. My name is Jerry Segan, I'm a paramedic. Do you have any books that you would recommend reading in regards to POCUS? More specifically pre-hospital, or, not specifically cardiac necessarily, but just POCUS?
Yes, I do actually, and I've been asking the same questions. I have a handbook right now in my purse that I'll show you. And there's a few others that I can give you names to. Yeah, I don't have them on the top of my head, but I'd be really happy to connect with you and share those. There's also the ultrasound podcast that is on YouTube. That is a pretty phenomenal resource that have been places that other experts and cardiologists have directed to me. And then there's also the POCUS Journal out of Kingston, and that's an app as well. And just so everybody knows, the ECG from the very first slide, that was a very subtle ST change. That was actually a 90% blockage of the left anterior descending artery, and it was only evidenced by POCUS.
So I've had the